Hello, this is Dr. Al Heuer. I am co-owner of A&T Lectures with Terry Shenfield, and I'm a professor at Rutgers University. During this session, I'm going to be talking about liberating patients from mechanical ventilation. Thank you very much for joining us today, and I hope that you enjoy this presentation. During this session, I will be focusing on the following learning objectives. Firstly, we'll be reviewing key terminology related to ventilator weaning and liberation. Probably most importantly, we'll be looking at the importance of collaboration and communication in this effort. Simply put, it is critically important that physicians, respiratory therapists, and nurses communicate effectively and collaborate in order to help ensure successful weaning and extubation of patients on mechanical ventilation. We'll also be summarizing some related research. So again, providing the foundation for this presentation is essential, and this foundation is really laid with the research that relates to weaning strategies and strategies for successfully extubating patients and keeping them off of mechanical ventilation. We'll review inclusion and exclusion criteria related to weaning and extubation. I'll also be summarizing how patients should be prepared. I use the term optimized, but probably better put, become the best version of themselves so that we can help ensure that they're successfully extubated and they stay free of mechanical ventilation. We'll also review and debrief some cases. So in order to take some of this theory out of the abstract and put it into concrete, how this could actually enhance your efforts in weaning and liberating our mechanically ventilated patients, we'll be discussing some specific cases. And lastly, but also importantly, I'll be providing you with additional resources for those who want to drill down and learn more about this topic. Regarding key terminology, spontaneous breathing trial relates to simulating spontaneous breathing for patients who have artificial airways such as endotracheal tubes or tracheostomy tubes. Many years ago, it was not uncommon to use what's called a T-piece trial. So that is basically setting up a jet or high flow nebulizer and either matching the oxygen concentration that the patient was on the mechanical ventilator or slightly exceeding it. So if the patient was on 40% or 35% on the mechanical ventilator, you could either match that or slightly exceed it on the jet nebulizer. Say if they're on 40%, put them on 45 or 50% on the jet nebulizer. However, it was recognized that this method also imposed additional work of breathing on the patient because, again, they were breathing through their artificial airway and not their anatomical airway. And of course, the artificial airway has a smaller lumen and therefore has much greater resistance and can impose work of breathing on the patient. So as a result, we often will use pressure support ventilation to overcome the actual resistance that the patient has, or we can use newer modes such as tube compensation or TC mode that's available in many latest generation ventilators in order to again overcome that additional resistance. Another term is weaning parameters. So these are metrics used to determine a patient's readiness to wean and potentially extubate. They include many parameters, but two of the most commonly used ones include NIF, or negative inspiratory force. Has to do with the patient's ability, and I'll say crudely, to suck in, to pull in a breath. And in general should be at least negative 20 to 25. That's assuming a good effort. It's assuming a good effort. So, our coaching, our ability to coach the patient has a lot to do with this. But if we think that it's a If it seems as though it is a reasonably accurate depiction, then we'd be looking for, again, a number of negative 20 to 25 or more negative than that. Vital capacity, basically after the patient takes a deep breath, is how much they can actually exhale out. Again, there's a forced vital capacity or a slow vital capacity. We're not going to get into that right now. But in general, normally it's 65 to 75 mLs per kg. However, for patients who are on mechanical ventilators, we'd be looking for a minimum of about 15 mLs per kg. Now, I'm almost 5'10", and I weigh about 180 pounds. So for someone about my size, we'd be looking for a minimum vital capacity of 1 to 1.2 liters. Again, that's a guideline. Another term is a sedation vacation or sedation holiday. So we reduce the sedation, often in the early AM, to, again, wake the patient up, have them in a more alert state so we can assess their ability to wean and follow commands and other indicators that I'll discuss during this presentation. In some cases, it's actually also called a spontaneous awakening trial. So in this slide, on the top of this slide, we talk about spontaneous breathing trial. Coupled with that is often a spontaneous awakening trial. Another term is a rapid shallow breathing index. So it's an excellent indicator of the patient's ability to ventilate, their respiratory muscle strength and endurance. It's basically the spontaneous respiratory rate over, so the numerator, the top number, spontaneous respiratory rate over the tidal volume expressed in liters. So it's really a decimal. If the patient has a spontaneous tidal volume of 400, it would be 0.4. And we're looking for a rapid shallow breathing index, or RSBI, lower than 105. I will drill down more on this concept in the ensuing slides. More terminology which bears reviewing. One of the terms is diaphragmatic fatigue. So what can happen is when a patient is not ready to be liberated and frankly is pushed too hard, too fast, so we're too aggressive with regard to weaning down pressure support, and they start to become stressed, short of breath. They start showing different signs and symptoms of fatigue, such as increase in respiratory rate, diaphoresis, the heart rate can go up, and other such indicators. The respiratory muscles may, in fact, be becoming fatigued with these signs and symptoms. And the problem is that it can often take more than 24 hours for the patient to recover. Another term is diaphragmatic atrophy. So as you can surmise, when we're weaning patients, we're really kind of walking a line between working them enough to avoid diaphragmatic atrophy, which occurs when the patient is on full ventilatory support, assist control, for long periods of time, many, many days. And we don't work their respiratory muscles, most notably their diaphragm. And those muscles can become atrophied. So we're walking that delicate balance between avoiding atrophy, but also not causing diaphragmatic fatigue. Another term is alveolar de-recruitment. So as we're weaning our patients, perhaps putting them on a TP's trial, just taking them off the ventilator, maybe a trach collar trial, things along those lines. The patient is no longer on positive pressure ventilation, and they're no longer receiving any PEEP. And they perhaps have become accustomed to this, or the PEEP and the positive pressure has actually been helping combat atelectasis. When we remove those strategies, when we remove the PEEP and the positive pressure, patients can de-recruit, and we just need to be mindful of that. We need to look at chest x-rays, we need to look at oxygen needs. So if the chest x-ray is worsening, if the radiologist's interpretation suggests that they may be developing atelectasis, if their oxygen needs are going up, which is also consistent with atelectasis, etc., then perhaps it may make sense to put the patient on the ventilator at night so they have positive pressure ventilation, they perhaps have some PEEP, and perhaps introducing hyperinflation therapy such as metanebs, IPPB, or other sorts of treatments during the day. Alveolar de-recruitment basically can work against successfully liberating a patient off mechanical ventilators. So we want to, do what we can do in order to minimize it, and if it does occur, to treat it. Recruitment maneuvers are another method in order to try to avoid de-recruitment. Some of the older methods involved intermittently doing a PEEP of 30 centimeters for 30 seconds or 40 centimeters for 40 seconds, things along those lines. There's some newer approaches that involve putting the patient on APRV, but not using APRV. It's airway pressure release ventilation in the more traditional sense, where you have the patient at P high for 5, 6, 7 seconds, and you have a release time, or a T low that's around a half a second, 0.6, 0.7 seconds, where the patient is still exhaling and then they go back up. Rather than do that with a de-recruitment maneuver, what you can actually do is keeping the patient for 5 to 7 seconds at T high, and then dropping them down 5 or 10 centimeters for another 5 to 10 seconds, but just doing this intermittently. So not leaving them on this, but doing it for 5 to 10 minutes, let's say every hour, every 2 hours, every 3 hours, as the patient tolerates it. When I say as the patient tolerates it, one of the bigger hazards of recruitment maneuvers involves hemodynamic compromise. So if the patient is already hemodynamically compromised in some way, the high PEEP, the APRV, but particularly the recruitment maneuvers can squeeze the heart, so tamponade the heart partially, reduce venous return to the heart, and reduce cardiac output, hence reducing pulmonary artery pressures, systemic blood pressure, and other hemodynamic findings. It's just something to be aware of. The last term here is wean per physician protocol. So I'll be discussing in this presentation aspects of weaning protocols. And the thing that I want to actually stress is that there's some patients, again, that can't tolerate 6 of pressure support. So patients sometimes can wean outside of the protocol, where perhaps they're weaning during the day on 10 or 12 of pressure support is tolerated, or weaning for 4 hours, then they're rested during the day and then they're put back on and then rested over the course of the night. So just to be aware, there's also other options that are in our repertoire for weaning these patients. Some of these strategies that are less typical of a spontaneous breathing trial of 30 to 120 minutes are often used in LTACs, where patients have been really difficult to liberate. They're then shifted to these facilities that really specialize in let's say less conventional means of weaning and hopefully extubating or getting a patient successfully to a trach collar. As promised, let's take a quick look at some examples of the RSBI, or Rapid Shallow Breathing Index. In the first example, we have a patient with a spontaneous tidal volume of 330 and a spontaneous respiratory rate of 15. As discussed earlier, the formula is basically the 15, so the spontaneous respiratory rate as the numerator, the top number. The bottom number is the tidal volume, or spontaneous tidal volume, expressed as a decimal in liters. So it would be 15 over 0.33 for a RSBI of 46. Provided all of the other barriers have been largely resolved, this is compatible with successful weaning and potential extubation. In the second example, we have a patient who's got a spontaneous tidal volume of only 200 and a spontaneous respiratory rate of 30. So 30 over 0.2 equals 150, and this on the surface would appear to be incompatible with weaning and successful extubation. The third example is a little bit tricky because the spontaneous tidal volume is 400. It's pretty robust. However, the spontaneous respiratory rate is 40. So 40 over 0.4 ends up being 100. So it's less than 105, but it's troublesome because the respiratory rate is so high. So in this particular case, however, it's significant that the tidal volume is robust. The respiratory rate is 40. You'd need to look at this case a little bit more deeply because this patient's respiratory rate may be 40 because they're wide awake, they're anxiety ridden because they want the breathing tube out. They may even be combative. So again, if all the other barriers have been resolved and this patient just looks bug-eyed in the bed and looks like I want that tube out and everything else looks like it's reasonable, this patient may actually be a candidate for extubation. But again, you'd need to look into additional information. A little bit more of a drill down on NIF and vital capacity has to do with our NIF normally, as I said before, is negative 60 to negative 100, sometimes even more negative than 100. Less than negative 20 to 25 is suggestive that the patient does not have sufficient respiratory muscle strength, perhaps even respiratory muscle endurance in order to be ready for long-term spontaneous breathing trial as well as extubation. The vital capacity, normally 65 to 75 mLs per kg. If the patient is intubated, we're looking for a figure that's greater than 10 to 15 mLs per kg. Or again, rule of thumb, somebody, a male 5'9", 5'10", 160, 170 pounds, we'd be looking for vital capacity in excess of 1 to 1.2 liters. So in the past few slides, we looked at measurements or metrics that relate more to ventilation. Now I want to shift our sights to some metrics that are aimed at oxygenation. And one of the more commonly used metrics is called the P to F ratio. And again, it's aimed at monitoring the adequacy of arterial oxygenation. The formula is fairly simple. It's the PaO2 as the numerator, the top number, divided by the bottom number, which is the denominator, which is the FiO2 expressed as a decimal. A normal P to F ratio for an individual breathing room air, such as ourselves, would be a PO2 of about 95. 90, 95, 100 over 0.21 or 21% oxygen that we're breathing would result again in a P to F ratio of 450. However, individuals that have either acute lung injury or full-blown ARDS will often have figures for the P to F ratio that are much, much lower than the mid-400s. The American Thoracic Society uses P to F ratio as one of the main indicators of the severity of ARDS. So if the patient has those concomitant findings of high, mean, and peak airway pressures, and a poor chest x-ray that has a ground glass appearance, if in addition to those findings their P to F ratio is between 2 and 300, that would be defined as acute lung injury. If their P to F ratio is less than 200, it would be ARDS. In Europe, where the Berlin definition is more common, if they had those concomitant findings that I just described, and they also had a P to F ratio between 2 and 300, that would be defined per Berlin as mild ARDS. If the P to F is 1 to 200, it's moderate, and if it's less than 100, it would be defined as severe. Still another oxygenation metric is known as the OI, or oxygen index. And the one thing I'll say about the oxygen index is it differentiates itself from the P to F ratio because it also accounts for mean airway pressure. And the biggest driver of mean airway pressure is PEEP. So P to F ratio does not consider PEEP. Oxygen index does. The formula for oxygen index is mean airway pressure times FiO2 as a decimal times 100 over the PO2. The lower the OI, the better. So targeted OI would be less than 20 to 25. OI values that are less than 5 are considered acceptable or even desired. Values in the 10 to 20 range do suggest impaired oxygenation, and OI above 25 associated with severe oxygenation disturbance and poor clinical outcomes. As I said earlier, unlike the P to F ratio, OI considers response to both PEEP and FiO2. And again, PEEP is a major contributor to mean airway pressure. As promised, I would talk a little bit about the research on which this presentation is grounded. So looking at what Rich Calais and others basically determined and published in 2018, they did a systematic review, and that basically involves looking at the research that's been done in the area of spontaneous breathing trials and using the strongest, the most scientifically rigorous studies and combining the results of them. And they found that spontaneous breathing trial combined with conservative sedation practices were associated with both reduced ventilator days and reduced ICU length of stay. Burns and others determined that automatic weaning using technologies such as SmartCare software. So SmartCare software looks at various physiologic indicators, looks at also at various ventilatory parameters, and will wean the patient automatically. Now, in this country, we use, or in some cases they use, SmartCare-like software, but the FDA said the changes cannot be made automatically, that a human being, an appropriately licensed human being needs to make the change. In other countries, in Europe and Canada, they actually allow the SmartCare to actually make the changes to the ventilator, such as titrating down pressure support. Battistella and others in 2018 determined that indeed the RSBI was the most frequently studied indicator in deciding whether to wean and extubate a patient. And Kuchek and others in 2017 determined that inability to follow commands independently predicted extubation failure. In neuro patients, so patients that have head traumas, patients that have ischemic strokes, hemorrhagic strokes, etc., that their ability to follow commands, to give you a thumbs up, to stick their tongue out, etc., is critically important. And what really it was saying was that their ability to do that is, provided all the other parameters were good, was strongly correlated with their ability to be successfully weaned and extubated. Now let's examine some of the key elements of a mechanical ventilator weaning protocol. Firstly, again, the patient should be assessed daily for readiness to wean. Some of the electronic health records have them embedded in them. The protocols will often call for, if you're on a mechanical ventilator, you should be assessed. Doesn't mean you're going to be weaned every day, but you should be assessed every AM, and in some cases also in the afternoon. With spontaneous breathing trial with pressure support to overcome the resistance, and we could calculate the resistance as shown here. As I mentioned earlier, alternatively, many the latest generation of mechanical ventilators have what's called tube compensation mode, or similar, maybe called something a little different, per their proprietary trademark, but basically a mode where you put in the size of the endotracheal tube, the amount that you want the ventilator to support the patient. It may be 100%, it may be 75%, whatever. And the ventilator will then do its thing in order to facilitate the weaning. Recommended length of time is 30 minutes to 2 hours, but again, the most recent literature suggests that you're going to know whether or not the patient's tolerating it in the first 30 to 60 minutes, so in the first hour. The criteria often includes a minute ventilation of between 5 and 12. It doesn't mean that if the patient's minute ventilation is 13, they're not going to wean, but again, these are guidelines. A minimum spontaneous tidal volume of 5 mLs per kg. So for example, an average adult male who is 70 kgs ideal body weight, that would equate to approximately 350 ml tidal volume. Respiratory rate less than 35. I'm not crazy about a patient who's sustaining a respiratory rate at 33 or 34 unless it's an anxiety-driven respiratory rate. But again, just as a guideline. The heart rate of less than 140 is targeted. Again, that's kind of the higher end of what you would tolerate, but it also recognizes that there may be some anxiety. Some of that may be actually driven because the patient's awake and anxious. A saturation greater than 90, preferably greater than 92, but it also recognizes that some patients, they live, even with supplemental oxygen at home, they live in that 90 to 92 or 93 range. It also recognizes that there's some more recent research that indicates or suggests that we may be over-oxygenating some of our ICU patients. I don't want to go down that rabbit hole too deeply, but it's just something to be mindful of. Rapid Child Breathing Index, as I said earlier, less than 105. Hopefully the patient can follow commands. The spontaneous awakening trial, they can follow commands. With neuro patients, it's particularly important, but bear in mind, if the patient's baseline suggests that they have severe dementia, they're not necessarily going to be able to follow commands. So it's not an absolute, but it's something that, if we know where their baseline is and they can normally follow commands, it can be an important metric. Extubation criteria, the NIF greater than -20, and some of the protocols call for more negative than -25. Deliberate cuff leak, particularly important for your patients that are mechanically ventilated for a long period of time, or if they've had an allergic reaction or angioedema or a traumatic intubation. So it's not absolute. We don't do cuff leaks necessarily for patients that were intubated for surgery. They've come up, now we're getting ready to wean them, etc. It's not a terrible thing to do, but it may be superfluous if the patient has a normal airway and they were intubated by anesthesia and it was unremarkable intubation. Weaning on pressure support greater than 10 centimeters for more than 4 hours is discouraged. Now, again, it's discouraged because we don't want to overwork the patient. We don't want to cause or contribute to diaphragmatic fatigue. However, again, some of the LTACs protocols, they actually call for, allowing the patient to tolerate that, particularly during the day, if they're on 10 or 12 or sometimes even 14 of pressure support, but they've been very difficult to wean. They may have failed extubation in the past, and you just got to make some sort of progress. So there are certainly exceptions. To complement the preceding slide that had key elements of a weaning protocol, there are related factors that really are aimed at trying to optimize the patient to facilitate weaning, or again, if it's not optimize the patient, it is create the best version of themselves, so we give them every opportunity to succeed in the weaning and extubation. And this includes looking at sedation, not just lightening it, but considering switching to a kinder, gentler form of sedation, such as Precedex, which tends to preserve the respiratory drive. Looking at I's and O's, so fluid input, fluid output, recognizing that patients, all patients have some insensible, they're not measurable fluid loss, okay? But really looking, if a patient is, 15 liters positive as far as fluid, that's significant. That's something that may preclude a successful, weaning attempt, or maybe they'll wean, but it really is something that says, let's just wait another day or two until they can diurese the patient and they can, get rid of some of that fluid. Proper nutrition, we now know that whether it's major surgery or major trauma, that those patients tend to need a lot of protein to rebuild tissue. So, ensuring that those sorts of patients have that proper nutrition in order to give them every opportunity to succeed. If it's a severe COPD patient, watching their carbohydrate intake and keeping that less so that their CO2 production is not excessive. Permitting adequate recovery time for failed weaning attempts, so building on that theme of diaphragmatic fatigue. Looking at adjunctive respiratory care, so if the patient's wheezing or has a history of asthma, continuing or starting bronchodilators and or inhaled steroids. If it looks like they have retained secretions, thinking about bronchial hygiene, thinking about things like mucolytics, CPT, maybe metanebs. Of course, suctioning the patient appropriately, not excessively, but appropriately. Airway optimization, so we'll take a little bit of a deeper dive into mucus shavers. So that is devices that are used to remove the biofilm that can start to build up on artificial airways, even as soon as 1 day or 2 days after that artificial airway's been in place. And another very important factor is adequate staffing and resources. So the AARC, so if there's any nurses listening to this presentation, the AARC is the American Association of Respiratory Care. AARC used to have guidelines where they said they recommended no more than 5 ventilators for one respiratory therapist. That recommendation has been removed, long removed, 15 or 20 years ago, something along those lines. So I don't want to be prescriptive. You know, I've had 7 or 8 ventilators. Thankfully, I don't remember the last time I had double digits, but I talk to my colleagues who sometimes do. And we all kind of know that there is a point at which, you know, you have X number of ventilator patients, and it really is, you know, you can't treat them all the same. You know, you want to think that you can, but you know, if they were all weaning, it would be a very difficult thing to do. So adequate staffing and adequate resources in terms of, you know, supplies and equipment are very important factors to consider as well. So mucus shavers can be used in order to remove the biofilm from the inside lumen of the artificial airway. We know that that biofilm will start accumulating within about a day of the placement of the artificial airway. And the biofilm can do a lot of things, but it also can reduce the inside lumen. It also contains harmful microbes, so we don't want it actually going down into the lungs. We also know now that the biofilm, the microbes in the biofilm, are not necessarily the same microbes, if there are any, in the airway, you know, the trachea, the lungs, etc. So it's really kind of important to remove them to help minimize the chance of a ventilator-associated pneumonia and to potentially give the patient the best opportunity to successfully wean. The research that circulates around the mucus shavers, Pincaroli in 2016, EndoClear. So I'm not promoting EndoClear. They're one of the manufacturers, determined that the EndoClear mucus shaving device is safe and can prevent endotracheal tube lumen occlusion. Bardes in 2017 compared the EndoClear group that actually have these mucus shavers with controls that did not, and it demonstrated a higher you know, pneumonia rate in the group that actually did not have the you know, the mucus shavers. Scott in 2017, interestingly enough, found that ET tube scraping can reduce airway resistance, but did not impact spontaneous breathing trial success. So this is one study, folks, but it is kind of interesting. One study does not determine a total practice there, but it is interesting that was kind of a paradoxical finding. So it's potentially valuable to take a look at various categories of patients in relation to their weanability. First category would be your quick wean. Patients, say, come up from the OR, they still have anesthesia on board, they start to clear it, they clear it, you know, hopefully quickly, the sedation is lightened up, and hopefully they can be extubated pretty quickly. Delayed quick wean, so patients who, you know, similar patient to the first example, they come up from the OR, but they're slower to clear the anesthesia, they're slower to clear the sedation. They may not be able to be weaned and extubated right away. Let's say they come up in, you know, 9 or 10 o'clock, 11 o'clock in the morning. They're not weanable at that time, but we do another spontaneous breathing trial assessment in the early or mid-afternoon, and they start to wake up. Again, this is where collaboration is really important, collaborating with the physician and the nurse. Let's lighten up the sedation. Let's maybe switch them over to Precedex, and we'll have a much more successful time in the afternoon that day. Weaning, but extubation is contraindicated, perhaps for a patient who has diaphragmatic atrophy. They've been on a full mechanical ventilator support for, you know, days and days, perhaps a week or more. They developed a diaphragmatic atrophy, respiratory muscle atrophy, and they need to be built up over a few days, maybe longer than that. So they can be weaned, but not necessarily successfully extubated until they demonstrate acceptable parameters such as, you know, rapid shallow breathing index and others. Marginal extubation candidates, so maybe patients who have an underlying history of COPD. They're improving, but, you know, they've just not been able to be successfully extubated, but they're headed towards being trached and maybe pegged in the coming, you know, days. So the idea may be to give them a shot and to extubate them, right, to maybe BiPAP or high flow nasal cannula. BiPAP if it's more of a ventilatory issue, high flow if they're, partial barrier is more oxygen related. No wean, no reassessment, so that category of patients basically should not be weaned nor reassessed that day. So it's not that they should never, but that particular day they should just be kept on full ventilatory support. So patients, respiratory failure, patients in septic shock, those patients in septic shock may also have hemodynamic issues, or they may have hemodynamic issues separate from any form of septic shock or anything along those lines. Alcohol withdrawal, and a host of other conditions that just really are not compatible with weaning. It's also important to consider contraindications to weaning and spontaneous breathing trials. So in some cases, inadequate oxygenation and the inability to, again, properly or appropriately spontaneously ventilate. So in the main, we're looking for patients that have PEEP settings that are not greater than 10 centimeters, an RSBI that does not exceed 100 to 105. We're looking carefully at how stable the patient is, and if they're not stable, non-reversal, the reason for intubation, hemodynamic instability, significant anemia, because obviously anemia would diminish the patient's ability to deliver oxygen-rich blood to the tissues. Sepsis, and even worse than that, septic shock, head and other sorts of trauma, if the patient is pharmacologically paralyzed, imminent major surgery. And this is a partial list, but these are some of the major items that would preclude successful weaning and particularly extubation. So there's also the category of patients who, again, are kind of in between. They're not at one end, they're not contraindicated from weaning, but they're also not quite ready to come off. And these would include your trauma patients who are stabilized, but they're scheduled for an additional surgery more imminently. Also patients on mechanical ventilation for extended periods of time, but who may have developed what I discussed earlier, diaphragmatic atrophy, and their diaphragm and respiratory muscles need to be built up over a period of several days or longer. Also included in this group are patients unable to protect their airway, but with a favorable RSBI. So patients maybe that have vocal cord paralysis, patients that may have mentation issues, so they have their status post-stroke, or a head trauma, something along those lines. In addition, patients with insufficient or absent endotracheal cuff leaks. So, patients that are at high risk for this, or if they've had a traumatic intubation, if they have some sort of odd anatomy, throat cancer, something along those lines, or if the patient maybe has had an allergic reaction, angioedema, something along those lines, where you're suspecting swelling. I'll talk more about the cuff leak in ensuing slides. Neuromuscular patients with marginal weaning parameters, and individuals who, they have supportive care issues. They're fluid overloaded, not excessively fluid overloaded, but fluid overloaded, nutritional concerns. We know that patients that have had major surgery, patients that have had major trauma, they tend to have high protein needs. So hopefully, they've been provided that. If they haven't, they really need to be, in order to enhance their chance of a successful weaning and extubation attempt. So as an adult ICU respiratory therapist, I'm sometimes asked, we try to assess them in the morning for weanability. They're not weanable at that time. Can we try again in the afternoon? And I've already referred to, there's certain examples where that's absolutely warranted. There's also some where it's not. So if the main reason why the patient was intubated to start with is not resolved, that may be sufficient justification for, well, we tried it in the morning, let's give them a full day, and then tomorrow we'll reassess them. Some specific examples, however, would include persistent respiratory failure, so oxygenation respiratory failure, ventilatory respiratory failure, poor acid-base balance, hemodynamic instability, severe anemia. Severe anemia would obviously affect the ability of the blood to, number one, get oxygen to the tissues, number two, remove CO2. Intentional heavy sedation for things like, your alcohol or drug withdrawal protocols, seizure protocols, and things along those lines. And as I said earlier, if the patient's pharmacologically paralyzed, that would exclude them as well. So to pull some of the themes we've covered in the preceding slides, in terms of enhancing extubation success. So three kind of chunks or three categories that we're looking at is pre-extubation assessment, pre-extubation optimization, pre-extubation augmentation, if warranted. So pre-extubation assessment, again, includes but is not just limited to adequate oxygenation and ventilation assessment, assessing the ability of the patient to protect their airway, helping ensure that there's no absolute contraindications. So the patient doesn't have poor weaning parameters on a good effort, because sometimes the weaning parameters are poor because the patient wasn't able to follow commands adequately or things along those lines. If the patient has an inadequate cuff leak, and we have cause to believe it's not because of gelatinous secretions that are around that cuff because the patient's been intubated for a week or something along those lines, that it may be real, that it was a traumatic intubation, or the patient had an anaphylaxis, something along those lines. That would be reason for, number one, not extubating the patient, and number two, recommending that the patient be started on a day or two of systemic steroids. Poor clinical status, so that's a lot of the things that we've been talking about, hemodynamics, fever, suggesting that the patient, may have an infection, looking at blood chemistry, WBC, so not just RBCs for anemia, but also, signs and symptoms of an infection, particularly one that's more widespread, excessive secretions, things along those lines. And again, I've touched on the fact if the patient can't follow commands, particularly if they're, if they're a neuro patient, that may be significant. Pre-extubation optimization, reversal of the reason for the original intubation, either, whether it's a total reversal or a reversal, we reverse most of it. Looking at fluid balance, looking at nutrition that we talked about earlier. And then the post-extubation augmentation for higher risk patients. For instance, a COPD patient that has an exacerbation, but the exacerbation part is really getting resolved. But they've either failed an extubation, or they really kind of have marginal numbers. Their saturation is 92, their RSBI is close to 100, it's not quite. It may be best to extubate a patient like that to non-invasive. A patient with marginal oxygenation, but their ventilatory status is decent, maybe we extubate them to a high flow nasal cannula. The key with extubating them to an augmentive device is to do it quickly. Either extubate them right to that device or soon thereafter if it looks like they're in need. This is just some of the evidence related to high flow nasal cannula. So the piece by Knee in 2017 basically says after extubation, high flow nasal cannula is a reliable alternative to non-invasive, can reduce the rate of reintubation. Dillon and others, 2017, basically ventilated patients at risk for recurrent respiratory failure have reduced reintubation rates when extubated to high flow. So it's something that absolutely should be considered in your marginal patients. So for patients that are, if you will, marginal from a ventilatory perspective, non-invasive should be considered immediately after extubation. A study here, 2013, Zhu and others basically found that non-invasive can reduce the need for reintubation and improve clinical outcomes, particularly for patients who have a marginal ventilatory status. Body and others, however, found that inappropriate use of non-invasive failure is associated with higher mortality. It's critically important that your respiratory staff be proficient in not just how to set up the equipment, but also how to manage the patient on it, and that your physicians are ordering it appropriately, not ordering it excessively, but certainly doing so when it's indicated in order to reduce the likelihood of reintubation. This slide, or this case, is actually talking about collaborating with our nurses, with our physicians, in order to get the weaning process started. The real importance of communication and collaboration. 47-year-old male, post-trauma patient, multiple orthopedic injuries, has been on assist control. All anticipated surgery has been completed. Patient's now clinically stable. A initial spontaneous breathing trial per protocol is not successful if the patient is not initiating breaths. So this patient's sedation needs to be lightened, perhaps needs to be switched over to Presidex. So this is where the nurse and the RT can have a conversation and appropriately reach out to the prescribing physician to get those changes made. In some cases, they're actually a bundled order where the protocol itself will actually permit, within certain limits, the sedation to be titrated to a lighter dose, and thus allowing the patient to wake up and hopefully begin initiating breaths. In this second case, we're examining a patient who can potentially wean but not be extubated. 39-year-old female, post-head trauma patient, recovering from her injuries during a sedation holiday and a spontaneous breathing trial. She's now initiating breaths of 20 breaths spontaneously at a tidal volume of 330. Her overall clinical status is stable. However, she's unable to follow commands. First question is, what is her RSBI? Her RSBI is numerator of 20, denominator of 0.33, or an RSBI of 60. What factors would influence your recommendation regarding weaning and extubation? Is the key factor here is her mechanics look good. I didn't give you oxygenation numbers, but when they're not given like this, the assertion is they're reasonable, they're acceptable. However, again, she can't follow commands, and we know that for patients, head trauma patients in particular, their ability to follow commands alone is a major predictor of their success regarding extubation. So this patient, wean, do not extubate. This third case is an instance where you might be weaning a patient but be reticent to extubate them. In this example, you have a 22-year-old female who's intubated for anaphylaxis. During the sedation holiday, her numbers look good. She's breathing at about 15 breaths per minute, and she has a robust tidal volume of about 400. Her overall clinical status is stable. She can follow commands. However, she does not have an endotracheal tube leak. Now, I will tell you that in some cases, patients may not have an endotracheal tube leak because they have gelatinous secretions that are up around the, if you will, just north of the endotracheal tube cuff. And it's really like, if you think of it this way, think of it as a false negative, that they don't have a leak, but it's not due to swelling. In this case, however, the patient has a very recent history of anaphylaxis. She may well have some swelling there. So this may be really an accurate depiction that she has a tracheal swelling and maybe needs to be started on a regimen of a day or two of systemic steroids in order to address that. Her RSBI, again, is very, very robust in 42, but I would say that this patient really should be recommended for a day or two of steroids and then reassessed for a cuff leak and weanability. In the fourth case, we're examining a higher risk patient. Okay, so wean, potentially extubate them to an adjunctive device. 69-year-old male on mechanical ventilation for 10 days, has that COPD exacerbation. RSBI during a morning sedation holiday is marginal at 102 on 6 pressure support. The saturation on 40% is 94%. This may actually be where this patient lives. We don't know. The patient is also on AARC-approved. They have an inadequate cuff leak of 150 mLs in the main for an adult patient. That's an acceptable number. Clinical status is otherwise stable. ENT, that's ear, nose, throat, has been consulted and is scheduled to assess the patient for a tracheostomy over the next couple of days. Is this patient potentially a candidate for weaning? Well, they are. Their RSBI is 102. They've been on 6 pressure support. So they are a candidate potentially for weaning. If they successfully wean all morning on 8 pressure support or on 6 pressure support, should they be extubated? We can consider it again. I would like to see this patient on 5 or 6 pressure support and assess them, reassess them at that time because they're marginal. But again, 6 to 8 would be certainly in an acceptable range. If extubation is considered, are there any special considerations? This case a bit contrived. So this would be a patient you would consider or strongly consider extubating them to a device such as non-invasive positive pressure ventilation. So in this particular example, it would be a patient who maybe is assessed in the morning for weanability, but determined that they're not weanable at that time and they should not be reassessed in the afternoon. The specifics of this example involve a 47-year-old male chest trauma patient who's mechanically ventilated. Chest x-ray reveals bilateral ground glass appearance, PO2 of 65 and 80%, PEEP of 14, P to F ratio of 78. So under that 100 threshold. So really very, poor oxygenation, severe ARDS. The airway pressures, in this case, I will expound and say the mean airway pressures are 32, pointing to low compliance. Again, the ARDS-net recommendation is to keep plateau pressures at 30 or less, preferably at 25 or less. So this patient is above that threshold. So again, has very stiff lungs. Should they be assessed for ability to wean? We can go through the machinations of assessing them. However, they should not be weaned. They're not even close to qualifying for being able to be weaned. Should they be reassessed in the afternoon? No, you shouldn't bother, because their apparent ARDS is not going to resolve in a matter of hours. It's going to take minimum to begin to significantly resolve, minimum of days. What other therapies should be considered? You can really be looking in terms of things like proning this patient, introducing things like nitric oxide, and potentially other rotating beds and potentially other modalities that will help support them until their body really has the chance to start to begin to resolve what looks to be an ARDS-like situation. In case number 6, we're looking at a patient who perhaps at risk for diaphragmatic fatigue. The patient had a marginal RSBI of 102, has been weaning on tender pressure support for 9 hours. Over the past 3 hours, however, his respiratory rate is climbing into the low 30s. Heart rate increased from 105 to 130. He's diaphoretic despite suctioning, bronchodilators, other respiratory interventions. Again, to try to ameliorate the climbing respiratory rate, heart rate, things along those lines. Pain and anxiety have been ruled out as a main cause of any sort of distress, increase in respiratory rate, increase in heart rate. What immediate action should be taken? So it probably would be wise to place this patient back on full support. And in doing so, it would be interesting to watch what happens with the heart rate and the respiratory rate. So in all likelihood, respiratory rate's going to come down. Okay, it'd be interesting to see what happens with the heart rate as well. If it returns to about 105, chances are the respiratory rate's going to lower as well. But if the patient looks less distressed, etc., then it suggests that maybe we were pushing them a bit too hard. What are some potential considerations for weaning over the next few days? So again, take it easy. This patient may need to be weaned off the protocol and weaned, for a longer trajectory on moderately high pressure support of 10 or 12, with the goal of trying to get them down to 8 or 6. When they have a sustained period where they can tolerate 6 of pressure support, maybe 6 of PEEP, then they may be ready to actually come off. This final case is designed to illustrate patients who may be at risk for alveolar derecruitment. We have a spinal cord injury patient who has an injury at C4, C5, so their phrenic nerve innervating their diaphragm is affected. They've been intermittently weaning on a trach collar during the day. The patient has repeatedly had episodes of hypoxemia after 46 hours of trach collar. A patient shows signs of bibasilar atelectasis. So this is, again, a bit of a contrived case, but it certainly looks like they're at risk for atelectasis. So, there's a lot of factors. Their neuromuscular disease certainly leaves them at risk for atelectasis and concomitant hypoxemia. Some of the recommendations would be what I alluded to earlier on, putting the patient back on the ventilator at night, using things like hyperinflation therapy during the day, and perhaps otherwise, such as IPPB, Medaneb, things along those lines. If there is mucus plugging, then mucolytics, suctioning, bronchodilators, etc. But again, this patient may benefit from, let's deal with the atelectasis, and hopefully we can eventually get them, tolerating the trach collar longer term. So let's try to summarize some of the key take-home messages from this presentation. Spontaneous breathing trials and weaning are important goals in optimizing vent patient care. However, to achieve these goals and to, if you will, make the most of the tools at our disposal, interprofessional communication and collaboration are essential. The nurses, the RTs, and the respiratory therapists need to collaborate on this. Fortunately, Many, if you will, tools and controls are in place to help facilitate this. Many of the electronic health records and electronic medical record templates have embedded in them, if you will, reminders. And they have, if you will, line items in the templates that basically ask the nurse and the respiratory therapist, has this patient been assessed for weanability? If they haven't, why? What barriers exist, and how can we overcome those barriers? What actions has the team taken to, overcome a patient that's fluid overloaded, for example? So thankfully, we have tools in place to facilitate interprofessional collaboration and to ensure that each individual profession is doing their, if you will, due diligence in helping ensure a successful liberation from mechanical ventilation. That said, spontaneous breathing trials in weaning are resource dependent. We need to have the adequate number of clinicians, of respiratory therapists, nurses, and physicians. And those individuals need to have the proper training, education, and support to enable them to actually deliver on those aims and those goals. No single method for weaning and liberation from ventilation are infallible. The data are mixed. We know that certain methods work better than others, but we know that no one method is without its limitations. It's important to constantly be examining that. However, some methods have stronger supportive evidence than others. And we know that by doing spontaneous breathing trials or assessing the patient for weanability on a daily basis is an important aspect that is supported by the evidence. We know that if you will, indices like rapid shallow breathing index, oxygen index, assessing the patient's P to F ratio are all critically important. Examining other issues like maybe diaphragmatic fatigue, diaphragmatic atrophy, de-recruitment, and using methods in order to, if you will, combat some of those barriers that exist. We need to use what evidence we have, but we need to also be open and stay tuned as more evidence emerges and that clinical practice guidelines and policies and procedures change and evolve to reflect the new evidence. This slide shows you some resources that may be useful to you if you want to learn more about this topic. Included amongst them are two of my textbooks, including Clinical Assessment in Respiratory Care and Egan's Fundamentals of Respiratory Care. I've also included a few of the other citations for the references that were used to form the foundation for this presentation. At this point, I want to thank you all for attending today. Hopefully you got something out of this that's actually will be useful to you in your practice, and hopefully you come back to A&T Lectures in the future for your continuing education needs. Thank you again, and have a great day. Bye.